This episode is being brought to you by our good friends over at CareStack. CareStack is the all-in-one cloud-based solution for seamless scheduling, efficient insurance verification, and in-depth analytics and reporting. Get a deeper understanding of your business with streamlined revenue cycle management and comprehensive clinical notes, all designed to elevate your practice to the next level. Visit carestack.com today to book a free demo. Tell them I sent you and get 2 months free when you switch over. carestack.com, carestack.com.
The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. All right, guys, it is a surgical Saturday. Whether or not you're listening to this on a Saturday doesn't really matter. So this is a surgical episode. So if you are looking for business, P&L, EBITDA, leadership, culture, systemization, all the stuff I love talking about, this is not your episode. This is surgically based, prosthetically based. And of course, on every surgical Saturday, I have my two great friends, Dr. Dan Brisky and Dr. Taher Dune, the founders of the Colorado Surgical Institute, which is just absolutely an incredible facility. Dr. Dune just settled into his new 16 operatory practice. So I was just there last weekend, and the new facility with the lecture hall and everything is just gorgeous. Welcome, boys. How you doing today?
Doing really good, man. I got parent teacher conferences here pretty soon, and just interested to hear what they're going to say about my boy.
Good, dude.
Yeah.
Off day for me. And it's funny, we're talking about prosthetics today because I had a patient that was waiting for me in front of my office this morning when I came in for an off day.
Oh, right.
His teeth popped off.
Was he
so
holding
some prosthetic issues that happened?
Was he holding an $8 Rosen screw in his hand? Like,
yeah,
is this important?
Yep. He was holding his entire printed arch in his hand.
All right. So today's topic is demystifying advanced prosthetics on full arch hybrid cases. No matter how good of a surgeon you guys are, if you are dipping your toe into the hybrid full mouth rehabilitation world, you've dealt with either an analog series of appointments that led to a fixed prosthetic that you eventually seat in the patient's mouth, or the digital workflow. There are certain hacks and certain tips that these guys are really good at articulating when it comes to the complexities of the prosthetic portion of the restoration. So we'll start with you, Dr. Dune. Let's talk about prosthetics and what are some of the common things that that lead to heartburn and frustration when it comes to the prosthetic side of these procedures.
Yeah, I think it's logical for people who aren't necessarily doing a lot of these cases to think the surgery is the hard part. But what we're finding is that the prosthetics on this stuff is the part that you lose the most stomach lining on. And the surgery component is once you get proficient enough and you're comfortable, actually ends up being the easier part of it. And then two, I think a common myth is when people are lecturing about this stuff, they're like, oh yeah, I see my patients 3 times and they're in their finals and it's super easy. And because you have 3D printers and it's $6 per arch to print it, things are easier than they've ever been. And I think that's sometimes the case, but rarely. I think usually you're still going to see the patient 10 to 12 times. You're going to be tightening screws. You're going to be adjusting occlusion. You're going to be doing cosmetic evaluations. People are going to be breaking stuff. Even if you give them a quick splint or some kind of temporary guard, they don't wear it. So I just want to, for anyone who's doing this and saying, well, why am I having like 12 appointments for people? It's normal. It's normal. It's absolutely normal. You're not alone in that. And what I will say, though, is once you get proficient, those appointments are very fast and quick and efficient, and they don't cost you a lot of money. But at the end of the day, you still have those appointments nonetheless. So we can start just from the genesis of this procedure and talk about like, okay, you can convert your dentures like we did back in the day, tall temp cylinders, bunch of acrylic, rubber dams, so you don't lock it in. And then talk about the smart denture conversion option, talk about 3D printers and going direct to multi-unit versus tie bases. And then we can talk about zirconia versus, a titanium bar with acrylic overlays, and kind of like where we are in terms of the prosthetic choices you can make. And so, Dr. Brisky, do you have like a preference necessarily on any type of way to gather records right now to go to direct to multi-unit?
I always think that I think there's two solutions, and it depends on how many arches you're doing a month, right? So one option would be photogrammetry. Another option would be something like an opti splint, right? So I always think of it in like two different camps. So what can we afford, what can we not afford in our practice at the specific time? And how do we capture the records so we do end up with a good result, right? Because maybe not all of us can afford the $40,000 iCam at this time. And just so everyone knows, the price will go up. I talked with the owner. I think he's actually increasing the price of that. So sometimes the price doesn't go down. It actually goes up over time.
Yeah. Interesting. And I think that has to do with the popularity of the actual workflow, largely in part to you guys, because you guys are on the forefront of teaching the digital workflow. And I think, I have to speak for just myself here. Myself and a lot of my associates got kind of disenchanted by the whole kind of hybrid restoration workflow, just because of the analog, all of the analog steps. And you just get kind of lost, and you end up paying a lab a lot of money to come over to your office to do the transfers and all that stuff. So it's just not fun. You're right. Like the surgical part, a lot of people think is the most difficult part, but unless you get a lot of reps with a current workflow, it actually is quite miserable. So, tell us the difference between photogrammetry and something like an opti splint. I was exposed to the opti splint for the very first time this past weekend. I found it fascinating. People say that it's less accurate than photogrammetry and something like an iCam or an iMetric, but tell us like the difference between those, Dr. Brisky.
So during the implant process, you have two things that you're trying to capture specifically. One thing is implant position, and the second thing is what the soft tissue looks like around the teeth later, right? So you have two things, soft tissue and implant position. Photogrammetry, the sole purpose of it is to gather the geolocation of the implant, right? So it just triangulates where exactly the position of the implant is through a camera lens. And then there are these little, almost look like little healing caps or comfort caps that you put on the multi-units, and there's specific ones for each photogrammetry system that you're using. And after you get a soft tissue scan of those little caps, the computer software meshes the implant location and the soft tissue location of everything. So then you have a complete picture. You have, where the implants are located, and where the soft tissue is located. In addition to that, you need three other things. You need what the teeth look like on the top. You need to know what the teeth look like on the bottom. And you need to know how the teeth come together exactly in terms of the proper occlusion. With photogrammetry, you can actually still introduce a lot of errors in terms of the soft tissue scanning. So when you grab a soft tissue scan with an intraoral scanner, whether it's Trios or Medit or anything, you can introduce errors by accident. So just because you're using photogrammetry doesn't mean that things can be perfect still.
Got it. Okay. So the soft tissue actually is captured by a traditional scanner like a Medit or iTero or that sort of scanner. But like at what point are you grabbing these actual scans?
Yep. And one more thing too. So when you grab an intraoral scan, and if you use a Trios or whatever machine, you can introduce double images by accident. So if you scan an arch, sometimes what you're doing is you're stacking images on images on images. And the goal is to have one image that's accurate. But using intraoral scanners can still introduce some inaccuracies. And what some people will do to get away from those inaccuracies are they'll grab an impression of what the tissue looks like, and then they'll either scan it outside of the mouth, or they buy what's called a desktop scanner. A desktop scanner, you could throw an impression in, or a denture, or a crown impression, and you'll get the exact, the exact model from it. It won't be any distortion associated with it. So that we'll talk a little bit later in terms of how to integrate maybe a desktop scanner into either photogrammetry or into using OptiSplint in an affordable way. Because OptiSplint is basically a series of metal posts that are just screwed onto each of the implants, and you're going to be luting the little jigs together with composite, right? And when you take it out of the mouth, you have a verification jig. So you know where the implants are because you just luted them together. So what you could do is you can scan that with intraoral scanner. But again, intraoral scanner can introduce some inaccuracies. So what a lot of docs will do is they'll buy a desktop scanner. And if you use a desktop scanner with OptiSplint, it's just as accurate at this point as photogrammetry because they have no way to introduce errors.
Awesome. Okay. So I'm getting it. I'm starting to pick this up. It's funny. The workflow at Colorado Surgical happens so fast, and the auxiliaries are so good at grabbing all of these images. Sometimes it's hard to keep track of like when they're doing what and what they're actually trying to capture with each of the scans that they're doing. They're very, very good at it. But this is great. Slowing this all down is very, very helpful. So, the OptiSplint yesterday or 2 days ago when I was over there reminded me a lot of that Duralay, that red Duralay stuff when you're kind of luting like plastic posts together to get the position of certain prosthetics. That's what it reminded me of, and it was very similar to that. So it's not as sophisticated as doing it digitally, but it definitely did the trick. The ones that I saw looked like it was really cool, and it'll save you $40,000. So that's a great way to kind of toe dip into these, especially if you're doing, one arch every 2 months or something. It's very hard to justify a $40,000 investment right off the bat. This episode is being brought to you by Large Practice Sales. Large Practice Sales helps doctors of all ages and specialties monetize a part of their practice with a silent partner. How does it work? National groups purchase between 51% to 90% of a practice for cash up front, and the doctor remains an owner leading their practice under their brand, team, and strategy. Doctors benefit from the resources of a larger partner to grow bigger, faster, and more profitably. Contact Large Practice Sales, or LPS, today to confidentially discover your practice's value in an IDSO partnership at no cost, without obligation. Just call 844-976-5332. That's 844-976-5332. Or visit largepracticesales.com/dentalpreneur. What do you got next, Dr. Dune, maybe?
Well, I think Dr. Brisky touched on a lot of important things, and now we're going to fast forward to, okay, now you have a 3D printed set of teeth that you're going to screw into the patient's mouth. And, you can use the Vortex screw. And if you just look up Danny Dominguez on like Facebook and message him, he has a really good product. Or you can look up DESS, DESS, and their 19.018 screw is a really good screw to screw these guys down to the direct to multi-unit approach. Now, keep in mind, if you're listening to this podcast in the future, you can always reach out to me and Dr. Brisky, because our opinions do change on things, especially in this space. So now you have teeth that you've screwed in, and you want to get the occlusion right. And so you got to just kind of evaluate, like, okay, are we in centric occlusion? Are we in centric relation? Are we an anterior open bite? Is the midline canted? The designers sometimes will make mistakes, or sometimes your records aren't good enough on that first set of surgical records to have the teeth look perfect on day one. Sometimes they're perfect and you don't ever touch them, and that's few and far between. The one I delivered yesterday, he was anterior open bite, and I had to just adjust occlusion to get him to close into the front. He still looked great, but all the teeth are tabletop flat in the back. So that's what I do. I just adjust the occlusion. I smooth out all the rough spots. I'll put a leaf gauge in there. And so what the leaf gauge is doing is this an anterior discluding element. So he'll slide forward on the leaf gauge and he'll slide backwards. And he'll slide forward on the leaf gauge and he'll slide backwards. So what that's doing is it's moving the mandible back and forth, and it's kind of loosening up the muscles and the ligaments. It's almost like if you bend over and try to touch the floor in yoga, right? The first time you do it, you can't hit the floor. And if you do it 10 times, you can palm the floor because everything is loose in your back and in your hammies. So at the end of the day, you're doing that with the TMJ. And then I check their occlusion and I'll adjust his bite as close as I can to centric relation, if possible. And then I make him a quick split, which is something for them to wear at night to take pressure out of the prosthetic and also allow the condyle to seat more. And then they're in healing. And then I like to see them 2 weeks later and readjust the bite, check everything. And then I like to see them 6 weeks after the surgery for x-rays to evaluate the bone levels around my implants. Sometimes I'll take the prosthetic off and take a look underneath. And then I like to see them either 8 to 10 weeks later after that and do final records again. But in that 10-week period, you might see them 8 to 10 times, depending on if they're a bruxer. Are they breaking teeth? Is something happening that we're unaware of that we got to kind of resolve? So there's a lot of nuance that happens in that first 8-week period that's very different based on the patient. They could have swelling of the tissue under the prosthetic. So a lot of docs will call me because we set aside time to do coaching calls with the CSI alumni docs. And they're like, yeah, this person's in immense pain post-surgical, right? They're feeling trapped. They're feeling pressure. They're feeling pain. Typically speaking, you take the teeth out, the swelling of the gums into the fixed prosthetic, all that edema is creating pressure. And if you take the teeth out and you relieve the pressure underneath your prosthetic, a lot of the time the pain goes away. It's not pain from the surgery. Nothing is failing that fast. What's happening is there's just swelling and there's pressure that's occurring. That's a really common thing that we see post-surgical. So you have to create enough room for the swelling to go into. And then fast forward, and we get to the 6 and 8 week marker. I'm sure there's a lot in there that I didn't cover on Dr. Brisky. Anything come to mind from that initial set of attempts through the initial healing period?
Can I back it up?
Yeah, go ahead.
Can I back it up just for a second here, just to make sure that we fill in all the gaps? So just from a higher level, what are we doing as far as vertical dimension? That was a big kind of topic of discussion at CSI this past weekend, particularly if you have somebody that doesn't have any posterior stops, so you haven't been able to maintain their natural vertical dimension. They have their edentulous in the back, or their edentulous completely in both arches or one. How do we get vertical dimension just off the bat? And then I have a couple follow-up questions after that.
Yep. Our brains are on the same exact track, Mark. I was literally about to talk about that.
Sweet. Thank you. Thank you.
So to prevent a lot of those issues that Dean was talking about in terms of anterior open bite, or the teeth are too small, or it's canted, or like all these little issues that we can get in terms of our records, it's important to remember that, a guy on his computer, maybe a few states away, trying to design your teeth, may not know where the teeth go. So we have to give him all the information he needs to develop a set of teeth for the upper and the lower that is occluding at the right bite, but that's also not too short or too thin or too wide, right? Like, how do we relay all these records? So what we do at before every surgery is the patient needs an upper. We need to know where the upper teeth are, where the lower teeth are, and where the bite's going to be. And we're also going to need to know where the bite is at the correct vertical dimension. So how far should the patient be open or closed? A lot of docs will come back with their prosthetic will be like these little tiny teeth, or if you ever make a denture, I see a lot of dentures that are made and the teeth are really, really tiny, right? And they break, or the denture fractures. So we need to be getting the correct records. And how we do that is, if you have a patient with teeth, what you do is you grab a scan of the upper teeth, the lower teeth, and the bite, where it just comes together right now. And they may have a little bit of malocclusion. But you also need to be checking the vertical dimension. There's a little tool called a VDO gauge. a VDO gauge will measure, and the measurements are based on a golden proportions rule. So that rule says that in 97% of people, the measurement from the middle of the eye to the corner of the lip will equal the measurement from the bottom of the nose to the bottom of the chin. And this is going to be at rest. So if you have a patient kind of open their mouth and then lick their lips and swallow, the point where their lips just touch is where you're going off of. So what you'll do is, if you get the measurement from the middle of the eye to the corner of the lip, and that's going to be the record that you're going to be going off of, and let's say that number is 70. Then you go to the bottom of the nose to the bottom of the chin, and now your measurement is 62. Well, you know now that you can open the patient 8 millimeters actually to get them back to their proportions. Because what if the patient has a substantial amount of attrition, or they have a denture on the top and they've lost their vertical dimension over time. So what we need to do is open the patient back up to their correct vertical, but we also have to give that to the designer who sits on his computer and will design the teeth for us. So you'll, again, if let's say a patient has teeth on the top and the bottom, you'll get a scan with your intraoral scanner for the teeth on the top and the teeth on the bottom, but you'll get a scan at the increased vertical after you open them up 3 millimeters or 5 or 6 or 8, whatever it is. So what I'll do to grab that measurement is I'll stick a leaf gauge in between the patient's teeth, and you'll remeasure the VDO gauge. So that way those two measurements will equal each other. And then you'll take a molar control bite or a tripod bite, and you're going to basically just put a leaf gauge in the patient's mouth, open them up until where the VDO measurement is close enough. And then you're going to squirt bite registration material on their molars or in the anterior area. Then you just take it out, and then with your intraoral scan, you're going to scan that as their new bite. So when you give the records to the designer, they're going to know exactly where the patient's bite is because you just spoon fed it to them. But a person on their computer doesn't know how far to open someone because the joint is built on a hinge, right? It's like open and close, open, close. So if you tell the designer, hey, you need to open this patient up, the designer is going to say, what are you talking about? Like where? Where do I put the teeth, right? Because he can't tell. He can't just automatically open it up in a software and give you a realistic position of where the teeth are going to be.
Yeah, that's really, really good. Okay, so you mentioned designer several times. I think we kind of skipped over the top of that. So after you get all these scans and they're accurately stacked on one another, you have the implant position, you have the soft tissue, whether you're using photogrammetry or you're using something like an OptiSplint, where do we send the scans to? So what exactly does a designer do? And is that scan good for the provisional as well as the final prosthetic, or are we taking another scan after they've been in a provisional for a period of time?
I think the initial records are good to reference off of, but they're really only good for the next step, I'd say. It's a good thing to have on record to see where the patient's teeth used to be. Maybe they say, hey, doc, I used to have a diastema and I really want that diastema back. Yeah. Right. So it's nice to know where the records were, but it's really only good for the next step, I'd say.
Mm-hmm. The designers are calling these stage 0, stage 1, and stage 2 records. So stage 0 is going to be your pre-surgical records. And so I'm using PowerDental right now. And as we sit here today, they are phenomenal. Like amazing. They're fast. They have good designers. And so what they're doing for me, and here's the thing is I used to do this way back in the day. And then I get away from something that worked. And now I come back to something that helps me hit my layups more consistently. And so in their stage 0 design, they pre-design everything and they create a denture with the occlusal part troughed out. So when I place the denture in the patient's mouth, I can see all my implants where they're placed in the bone and I can see where the teeth are going to be for the patient. And I can envision where my multi-units are going to come out from. So I can put my multi-units in surgically in the right location, which saves a lot of time. And it makes the prosthetics really thin. So the stage 0 component is a good stage to incorporate into there. Stage 1 is then going to be your surgical records that you actually take at the time of surgery after the teeth are out and the implants are in. And then they use stage 0 and 1 records to make your first prosthetic that you give to the patient the next day. I like to do a next day delivery unless the patient is adamant on having this done that same day, because it gives the time for the designers to do their thing, your team to process and do it all. And the patients are tired. I send them home. And if they travel from far, I tell them to get a hotel and come back the next day. And then we deliver the teeth. And so that's how I like doing it. And that's what PowerDental does. And they do it very well. And they also have really cool fiduciary markers that have increased the accuracy of the occlusion that I'm getting on my cases. So that's how I like for them to do that.
Yeah. And Mark, so remember, you're probably thinking the same thing I am right now, right? Everyone out there is thinking, well, you got the records, but you sat the teeth, but how did you go from there to there, right? Like how is your bite still coming together correctly? And that answer is, let's say you take the most perfect records in the world. You got the best intraoral scan on the top and the bottom. You got the occlusion bite, and you gave them the vertical dimension, and then you take out all the teeth, right? Well, if you get a scan and all the teeth are gone, how in the world is the designer going to know where the teeth used to be if he can't see it now, right? He has no idea because you just removed all the teeth and placed implants. So he can't magically put the two scans together to see where the teeth used to be. So what Dr. Dune was mentioning was fiduciary markers, or TADs. What that means is you're either intentionally leaving teeth behind, or you're going to put a screw that's in the retromolar pad area or the third molar area or on the palate. And you're going to put these in while the patient still has their teeth in. So right before you start taking the teeth out. And after surgery, the fiduciary markers are still in there. So now he can mesh the scan from before when the patient had teeth to the scan after when the patient has no teeth and there's only implants in. So he can mesh those two scans together. And now the computer designer has everything he needs. He has the before records. He has where the implants are located in terms of the implant position and the soft tissue. And he can merge all those records together. And that will provide you with occlusion that just comes together with almost no adjustments.
That's beautiful. Okay, so here we are. We're at the provisional stage. Now, what's the timing look like? How quickly can you seat the provisional, Dr. Dune? I know the answer, but I want you to talk the audience through this. How quickly can you seat the provisional? How long are ideally they in the provisional before you go to a permanent prosthetic?
Yeah. So, and one other thing, I'll take one step back on the surgery. What I've started doing is placing my implants 2 to 3 millimeters below the bone. So then my multi-units are a little bit lower than they used to be, which means the emergence profile of my prosthetic is lower and in the tissue more than it used to be, which protects the implant from bacteria and food accumulation. But it also allows me to build the prosthetic flat. So now there's no concavities in it, because the concavities are going to trap food and bacteria and not be cleansable. And so if you can have a flat prosthetic underneath, the way to achieve that is through deepening the placement of your implants and allowing for the lab to make it really flat and control the tissue. And then when you fast forward, you can deliver your prosthetics the same day. You can deliver them next day. A lot of people who are doing full arch a lot are doing next day deliveries. Doesn't mean one is right or wrong. It's just whatever works in your practice. And then after that, let's say everything is uneventful from a healing perspective. If you get max torque on your implants, it's a very stable case. You can take you can tighten your multi-units again, and then redo your photogrammetry scans or your OptiSplint records at your 10-week to 12-week marker. If the bone is soft, if you place this and you're like, hey, I mean, this is like D4 bone, I don't have a lot of stability, maybe wait 16 to 20 weeks before you torque your multis again. Give it extra time to bake and for the osseointegration to occur. And it can help prevent like spinning of implants. And before I do that torque appointment, I talk to every patient. I'm just like, hey, you may lose an implant here. When we tighten these parts, if your body rejected it, it'll come out and won't be a problem. We'll just keep moving forward and we'll replace it. But I say that before I torque every implant. So if it does happen, and it's very rare that it happens, it's like 2% of the time it happens, but then the patient's not freaking out because I've already pre-addressed what may occur in 2 out of 100 times.
Yeah. I like that. And it all is about framing and the narrative that you choose, the words that you choose to use. Unfortunately, or we don't even use the word unfortunately, your body rejected these implants. We see this happen a lot. Actually 2 out of 100 times you're just happened to be for this particular implant that has happened. No problem. Here we go. And here's, the course of action that we're going to take. I like that. Very, very important to be able to frame that and don't take that one on the chin. It's nothing that you did wrong. And if you're discussing that and you're open with that from the very beginning, I think that makes all the difference in the world as far as patient perception.
The most common complication I've been seeing actually in my own practice is actually incision line openings. So the most complication, I've had my first implant failure in the private practice since I opened my startup about 6 months ago. So knock on wood, I don't have like 10 more come back because I just said that. But it was actually because I had 2 patients. Both of them would pull their lower lip down and they were brushing the incision line literally 3 days after the surgery. So I had one that I'm going to resuture actually tomorrow. And then the other one, it granulated in and looked perfect. I didn't really see white bone. It just kind of went back in. And then I was like, oh, cool. I don't have to suture this because the lip just tucked right back into where it was supposed to when he stopped messing with it.
Mm-hmm. Gotcha.
So I have to resuture those. And that was a big bummer. But I think the importance of giving your patients just really strict guidelines like, hey, don't look at it, don't touch it, don't squish, don't brush, don't do anything for the first week is really helpful. For sure.
Dr. Dune, any last thoughts? I want to get you to your parent-teacher conference. You guys worked through this workflow really, really well. Any last thoughts before we close this thing up?
No, there's a lot more that's going to go into it, and we can definitely do it on a follow-up episode. So many cases are so nuanced that we can have this conversation and cover like all the pearls and things we have. What I'd recommend is just people reach out to us. Dr. Brisky and myself have time allocated to talk about these things. And so if you take pictures, post it on DSN, join DSN if you're not on DSN. But if you're on DSN, take pictures of your x-rays, of the cosmetics, of the patient, and post it on DSN. A lot of people can learn from this. And we'll come on and specifically answer the nuances of your specific case and give you feedback. And if it needs it, we'll give you our cell phone numbers and we'll hop on a phone and just talk you through what we would do in private practice because we've been doing this long enough and through Colorado Surgical and like we're managing 18 arches per course that we run. And then all of the patients afterwards, we have so much complication reps in us. And usually it's easy complications that we can talk someone through. When we use the word complication, it doesn't mean catastrophic. So I would just really encourage everyone to like start posting their cases in a safe place. Like Facebook sometimes isn't necessarily as safe as like a controlled forum, like a DSN forum. And we're here to help. And there's a lot that goes into it. But once you start doing enough of these, it clicks. It's like when you start to learn to speak another language, all of a sudden it's like it makes sense in your brain and it all sounds correct. That's just how surgery is. You just need a lot of repetition to truly understand the nuances of it.
Awesome. Any final words, Dr. Dan Brisky, before we sign off?
No, just be better. Always keep improving, right?
Awesome.
I continuously run into more and more complications or new things I learn even still to this day. So I'd say just anyone, post as many cases as you can. Don't be shy. Don't be afraid to learn from your failures or from my failures. Right? That's how you get to the end result fastest.
Yep. All right, guys. As always, really valuable information. Thank you so much for sharing and downloading that part of your brain. Can't wait till the next Surgical Saturday. I'm sure I'll talk to you before then. Ladies and gentlemen, the founders of the Colorado Surgical Institute, Dr. Dan Brisky and Dr. Taher Dune. Hey Doc, are you overwhelmed, sick of being the bottleneck, not sure where to jump in and tackle projects? The idea of having an assistant may seem like a luxury and something you don't need. However, as practicing clinicians, business owners, husbands, wives, moms, and dads, you may be holding yourself, your business, and even your family back by not delegating day-to-day tasks and maximizing your valuable time. If you guys have heard our podcast and webinars before, you know I hired a personal assistant 8 years ago and haven't looked back. I hired Ashley Evans at the time, now Ashley Hirschfeld, and we were able to execute, prioritize, and launch projects and businesses that have led to multiple streams of income and invaluable peace of mind. Ashley has now founded GSD Queen, where she is helping busy entrepreneurs and business owners find the right personal, virtual, or executive assistant to help you get the momentum you need to reach your goals. With Ashley's assistant program, you get one-on-one consultation with her to create your perfect personal or executive assistant avatar and ad. Execution of placing ads. Review of resumes. Skill and personality testing to narrow down to 2 to 3 candidates. Guidance in maximizing in-person reviews. After selection and hire, the assistant will receive 4 weeks of GSD Queen Bootcamp, where they will learn the tips and tricks to being an efficient and forward-thinking assistant. Reach out to Ashley directly at 928-910-3599 for more details and more information. If you happen to be a DSN member, reach out to Ashley inside Workplace to get a $250 discount. 928-910-3599. Reach out to Ashley and get ready for a life-changing experience. And that wraps it up for another episode of the Dentalpreneur Podcast. Look forward to reconnecting on the next episode.
Thank you so much for joining us today on the Dentalpreneur Podcast. Check out TrueDentalSuccess.com for full recaps of every show, a schedule of our live events, free video tutorials, and a whole host of practice building resources.